Good morning, everybody. Welcome to Pediatric Grand Rounds. I have the pleasure today of introducing Dr. Sarah Kinter, who's an assistant professor in pediatrics, Division of Craniofacial Medicine at the University of Washington, and a PI with the Center for Child Health, Behavior, and Development at SCRI. She earned her BS in Speech and Hearing at the UW, her MA in Speech Language Pathology at Northwestern, and a PhD in Epidemiology at the University of Washington. Dr. Kinter began her clinical career in 2006, joining the Seattle Children's Craniofacial Center as a speech-language pathologist. She's nationally recognized for her expertise in the differential diagnosis of complex speech disorders. Her research program focuses on improving our understanding of the intricate relationship between orofacial structure, speech function, and perception of functional impact in individuals with craniofacial conditions. So excited to learn from you today. Welcome, Dr. Kinter.
Thank you very much. I am very excited to be here today, to those of you in person and those of you online. I have no disclosures. And also I wanted to start with a land acknowledgement. So we recognize the traditional unceded lands of the many indigenous communities and tribes our facilities occupy across the Washington, Alaska, Montana, and Idaho regions. We honor with deep gratitude the land itself and the people and tribes past and present who have called the land home. This acknowledgement does not take the place of authentic relationships with indigenous communities, but serves as one way to honor the land we are on. So after floating around a little bit in my undergrad, I ended up at the University of Washington and got my bachelor's degree in speech and hearing sciences, and then went on to Northwestern, where I earned my master's degree. And in speech-language pathology, the clinical degree is a master's. And so I started my clinical fellowship year, an early career at what was then called Lucile Packard Children's Hospital at Stanford. I believe it is now just called Stanford Children's Hospital. And then a really long time ago, before the branding changed, I came to Seattle Children's. And shortly thereafter joined the Craniofacial Center. And as I developed my career and went through rebranding many years ago now, my primary clinical focus as a craniofacial speech-language pathologist is to differentially diagnose speech characteristics as either related to structure and therefore needing some sort of surgical management or functional needing speech therapy. And also my role is to provide anticipatory guidance to families regarding the expected outcomes for treatment or surgical recommendations. However, as I became a more seasoned clinician, I often had more questions than answers, and a growing sense that I wanted to have an impact on my field beyond what I can contribute in day-to-day patient care. And so rather than purchasing a fancy car or sailing around the world, my midlife crisis was to earn a PhD. And I did this in epidemiology for the purpose of getting rigorous methods training. I graduated in 2021, and I'm now with the Department of Pediatrics and the Division of Craniofacial Medicine, and a PI with CHBD, and then I still maintain my clinical care through the Craniofacial Center. So we all have an underlying motivation for why we do what we do as clinicians and as researchers, and for me, it is this. Communication is at the heart of who we are as human beings. It allows us to connect with others, to exchange information and ideas, and to express our feelings. Article 19 of the Universal Declaration of Human Rights states that everyone has a right to freedom of opinion and expression, including the right to seek, receive, and impart information and ideas. What happens, though, if we're exercising our right to communicate through speech, but our audience, a parent, a friend, a teacher, is unable to understand the words that we're saying? What if you send your child off to their first day of kindergarten and they come home to tell you about their day, like this child?
Is about like and I saw it in a new book called Ice Monkey. I thought the movie. Well, he's real, so he's not
And so how do we ensure that this child can communicate in a way that allows them to express themselves to their families and to establish friendships with their peers? These questions are why I do what I do as a speech-language pathologist and as a researcher. So I'm hopeful that by the end of this talk, you'll be able to outline the physiologic components of speech sound production and how they interact to create fluent and intelligible speech, to analyze the potential impact of atypical anatomy on speech function, and to illustrate how the perception of one's speech should be considered in both clinical diagnosis and in research outcome measurement. So first, I want to acknowledge that there are many components that contribute to a successful and effective communicative interaction. There are many speech-language pathologists across this hospital that touch on each of these. And there is also a lot of overlap and dependency between the different components that also contribute. So for this talk, however, I'm going to be focusing just on the speech sound production piece. And so there are three broad areas to consider when evaluating and measuring speech sound production. First, what structures are involved? Are there any structural differences that could be affecting how the person's speech sounds? And second, the function. How is the anatomy of the speech system working? Is it coordinated? Is structure preventing normal function? Is the structure intact, but the speech sounds different because of motor or other learned characteristics? And finally, independent of clinical diagnosis, how does the person's speech impact them in everyday life? And if so, is it significant enough to warrant surgical correction? And do differences present cross the threshold of becoming a problem they wish to correct? All of these must be considered when evaluating how a child or an individual produces speech. To further complicate things, there are over 100 muscles involved in the production of verbal speech. There is a lot happening in a short amount of time. And so I'm going to let this video illustrate how complex speech is for me.
Speech production is possibly the most complex of human behaviors. In 1 second of fluent speech, we can produce approximately 5 or 6 syllables comprising 10 to 12 phonemes and a variety of articulatory gestures. This requires coordinating dozens of muscles from the diaphragm and rib cage used to provide the source of sound as air passes through the larynx, to the tongue, lips, and jaw, used with precision to shape the chambers of the vocal tract.
And so while watching that video, you want to pay attention to 3 primary things. First of all, the larynx is moving up and down a bit. The soft palate is going up and down depending on the different speech sounds that are being produced. And the tongue and the lips are doing all kinds of gymnastics getting into the right places for the right sounds. And all of this is happening very quickly. And so as you can imagine, any change to the structure in any part of that system has the potential to impact other parts of the system as well as the system that structure is involved in. And so this is admittedly a much less cool video, but it is one that illustrates the function of these 3 things I'm talking about. On the left here, this patient, you can see that the palate is closed against the back wall of the throat, and this allows separation of the nose from the mouth during speech. And when this person is making the sound, in this case it's an SH, a sh, I believe, you can see that air is coming up from the lungs, going through the vocal cords, and is being directed only out the mouth. And there is some point of constriction here because of the tongue placement. On the right here, you can see that the palate is open, and the tongue is in a slightly different position. because there is a vowel following that SH sound. And so when the person produces this sound, the palate is supposed to be closed for SH, but it is open. And so you're going to see air coming through the mouth and the nose. So this is VPI, or velopharyngeal insufficiency. And all that means is that the movement of the soft palate to the back wall of the throat is not enough for speech. There's something structural there that's preventing that closure, and this patient might need surgery to correct that. So putting this all together, fluent, intelligible speech requires coordinated function of respiration, which is inhalation prior to the onset of an utterance, and then with controlled release. Phonation, which is just whether or not the vocal folds are vibrating or not. Articulation, which is the placement of the tongue, lips, and jaw to shape each sound. And then resonance, which by definition is just the energy that's present during speech that is created as sound and air moves through the vocal tract. So any change to the size, shape, or other morphologic characteristics of structures involved in speech may alter the speech sound production. So an example, if you put in a trach, you have now changed how airflow is moving through the system. And airflow can now not get out up into the mouth or the nose or even into the hypopharynx because it is coming out the trach so that the patient can breathe. Now, certainly, airway wins every time when it comes up against speech, but it is something that we're striking a balance between. And going back to the motivation for why we do what we do, when we make changes like this, we need to make sure that we're addressing the functional change that is made. And so if a patient has a trach, we need to be thinking about how to reestablish their ability to communicate, whether it is through a speaking valve, or if they're not a candidate for that, through augmentative communication or some other mode, so that they can express themselves. So as you can imagine, this, all of these structural components become very relevant in both my clinical work and in my research in individuals with craniofacial conditions. And so from here, I'm going to focus primarily on speech considerations specific to cleft palate, although the question of structure versus function versus perception is applicable to any craniofacial condition that affects speech physiology. So this is just diagrams of different types of cleft palate. Panel A there is a normal palate. And you can have different types of clefts moving from panel B there. That is just a cleft of what we call the secondary palate. It involves the posterior hard palate and the soft palate. You can also have a unilateral cleft lip and maybe alveolus, which is panel C there. That does not involve the soft palate. Panel D does also not involve the soft palate, but is a bilateral cleft on both sides. And then E, there is a unilateral cleft lip and palate, which impacts the lip, the alveolus, through the hard palate, and all the way through the soft palate. And finally, that last panel there, F, is a bilateral cleft lip and palate, and so it goes through all the hard palate and into the soft palate. And this picture on the right here is a submucous cleft palate, and this patient is phonating and saying ah when the picture is taken. And you can see there is a tenting. We call that tenting, where there's that triangular shape, contour of the palate, and then this patient also has a bifid uvula. A submucous cleft palate just means that there's a cleft in the underlying bony structure, but then it's covered with mucosa. Sometimes these are functionally a problem, and sometimes they're not. And so looking at intact velopharyngeal anatomy, so on the left, we have here, this is the maxilla, the hard palate, the roof of your mouth. And on the back, this sling-shaped muscle is called the levator veli palatini, or we call it the levator sling. And this is the muscle that is primarily responsible for elevating that soft palate during speech. And then behind here, you see the muscles of the posterior pharyngeal wall are present. And so in normal speech, these muscles are going to come forward, the levator sling is going to elevate, and sometimes the side walls will come in, so you get complete closure of this space. This is the anatomy of an unrepaired cleft palate, and you can see that that levator sling now comes in and it inserts anteriorly. And so there is no muscular anatomy or function there to elevate that soft palate for speech. And so these patients, if they're attempting to say certain sounds, they're getting a lot of nasal air escape, both through that velopharyngeal port and also, if it's an unrepaired hard palate, also through the hard palate. So the primary outcome of initial palate repair is restoring that levator sling to allow typical speech production. Functionally, kids can do anything that they need to do with an unrepaired cleft palate except produce intelligible speech. And so speech is a really, we focus on that as an outcome quite a bit. When this muscle is not functioning properly, you get what I mentioned before, VPI, which is just nasal speech due to the inability of the soft palate to close against the posterior pharyngeal wall. Across studies after an initial palate repair, the risk of VPI is somewhere between 10 and 30%, and that varies because of many things, one of them being how VPI is measured, the protocols, the timing of palate repair, the type of palate repair, where the palate repair was done. There's a lot of factors that go into that outcome measure. So there are three primary structures I'm thinking about as a speech pathologist evaluating speech in kids with cleft palate. The first one is the hard palate, and in this case, we're really looking to see if there's any residual fistula that's there. And the impact of the fistula is going to be dependent on the size and location of the fistula. And so if you look down here, these different colors are all the places of articulation of all the different consonants in English. This represents English. And so if you have a fistula kind of right in the middle of that hard palate, like these two patients do actually, what happens is that airflow is coming up from the lungs through the vocal cords, vocal folds. The soft palate might be elevating, but that airflow keeps going into the mouth where it should, but then it's sneaking out the fistula. And so you've got nasal air escape for a different reason. Sometimes patients will unconsciously recognize that these are present, and they might like flatten, rather than like elevating a tongue tip, they'll flatten their tongue so that it occludes the fistula. And so sometimes you can't tell that there's something there in their speech because they're functionally compensating for it. And so this picture above here, actually, this is a fistula I think that had been there a while, and we just hadn't seen it until we actually managed his VPI, and his speech was better, but I couldn't figure out what was going on. And I got a dental mirror so that I could see straight up, and lo and behold, that's what was present. I had a patient Monday in clinic who, dad, he was 3, and so the hard thing when you're looking in somebody's mouth, you're looking across. And so if there's a fistula there, you might be missing it if it's kind of around a ridge of tissue. And so I'm always trying to, standing on my head practically to try and get the right view. And I had a dad the other day who just lifted up his 3-year-old son by his feet, and I was able to just look down and see it was a great view. And fortunately, the child was totally okay with it. The second primary structure, and one that we talk about all of the time, is of course that soft palate or the velum. And these are different examples here of what you might see on an oral exam. And so again, this patient is phonating and doing what we call tenting. And what this tells us, we think, is that That muscle that I mentioned, that levator sling, is inserted anteriorly. And so when you're getting contraction, you're seeing it contract here, but it's not moving all the way across because the muscle isn't present there. Down here, of course, is a bifid uvula. This is post-surgically bifid. This patient's already had palate surgery. And then this is just another submucous cleft palate example, and that dark stripe down the middle is what we call a zona pellucida, and it's just a translucency because the underlying bony structure is not present, and so you're able to see straight through the mucosa. So I'm going to play some clips of what VPI sounds like. The first clip I played, The first clip I played at the very beginning, illustrating my motivation. That patient also has VPI, so lots of nasal air escape, hypernasality, difficult to understand. And so these are just some other examples.
Mama made lemon jam, pone for baby puppy, David cake for cake. Sissy sees the sky. Jem and Charlie Chew go 1, 2, 3, 4.
And this patient, it's also VPI, but the most noticeable thing here is there's like a turbulent nasal air emission that's present. Their overall resonance quality isn't too bad, but the nasal air emission is kind of distracting.
Hold the baby puppy, give cake for cake. Sissy sees the sky.
My kids can repeat these sentences over the years. They hear me doing talks. Yeah.
61, 62, 63, 64, 65.
Okay, and on the right here, this is a lateral video fluoroscopy, and we do this sometimes if we're considering surgical management of VPI. And so here you see the soft palate, and this darker line here is just a line of barium that we've put in the nose. And what should happen is this palate elevates and contacts way back here to the posterior pharyngeal wall, and as you can imagine, it's not going to quite make it.
Hold the baby puppy. Take Teddy to daddy. Give cake to cake. Sister Susie. I spy a starry sky. Jim and Charlie chew gum.
And so you can see there's, for all of those sounds, there's consistently like a few millimeters there that is open. And because that closure or lack of closure is consistent, we're probably talking about needing to do something structural, whether it's surgery or an obturator for this patient. So I'm going to play this audio file and think about this in comparison to the previous ones I played on the last slide.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20.
So speech isn't too bad, huh? Not nearly as nasal as the previous ones. There's no turbulent nasal air escape that's distracting in the speech. This is the patient's oral exam. So this is an example that structure and function are not directly correlated with each other. Just because there's something structural that you see that's different does not mean that there is a functional problem that needs to be, quote, fixed. And so this is something we talk a lot about with families. And unfortunately, there's a lot of misinformation out there, and there are times when families will come to us and somebody has said, I see a submucous cleft palate, for example, and you need to have surgery to fix this. And then they come and we have a different conversation depending on how their speech sounds. And so I think that this is just an example and maybe a plug for those listening to be open-minded about recommendations and just say, I'm seeing something different. I think it would be a good idea for you to see a specialist who understands this and see if it's something that needs to be addressed or not, because it is a challenge when we're undoing what somebody else has already said. Some families are so thrilled that their child doesn't need surgery, and others are very frustrated because there's lots of speech problems that they think can be fixed with the submucous cleft palate, but that is not the case. It is something else, and so doing surgery would not have any functional impact. And we know that, so when we're talking about a structural difference, we're potentially talking about surgery. And there's nothing, light about surgery. It's kind of a big deal to do. There are risks and benefits to every single surgery, no matter what it is. There's also the potential that you create a new problem by fixing a different problem. And so we don't take the recommendation for surgery lightly. And we want to make sure that we think there's potentially a functional benefit, and that the family understands what that functional benefit is going to be. So this on the right here is kind of the opposite problem to what was on the left with that structure-function dynamic. This patient, you see that palate, again, this is a lateral flora, you see that soft palate elevate, and it closes very nicely against the back wall of the throat for cookie for K, puppy ate a pie, there's a couple other sentences. And then when they say sissy sees the sky, they say nifty. And so you'll see that soft palate is way open for those sounds. And it's only on that S. And so if you think about if you went in and did surgery to correct the quote S, what would happen with the other sounds? They're fine. And so what we're dealing with here is something that people perceive there to be a structural problem, but it's actually a functional problem. The person has learned to make S for whatever reason by holding that palate open. And so this patient should not have additional surgery to correct speech. Baby buggy.
Oh, baby buggy.
Give cake the cake.
Give cake the cake.
Sissy sees the sky.
Sissy sees the sky.
Jim and Charlie chew gum.
Jim and Charlie chew gum.
And count 1 to 20. So you can see there's a distinct difference there. A caveat, we don't normally image those that have these kinds of errors because we're not talking about planning for surgery. This was a case where there needed to be some education for the family and all involved for what was really happening. This video, I've been using this video for years. I think I need to upgrade it a bit. And finally, that third kind of structural thing that we're considering in kids with cleft palate is the occlusion. And so many patients with cleft palate will develop an underbite or class 3 malocclusion by adolescence on the left here. And you can see that the tongue sits in the mandible. And so when the upper jaw is further back, that tongue is still forward where the mandible is. And so that's going to make it difficult for this patient to say sounds where the tongue placement is supposed to be more forward in the mouth. Those are sounds like T, D, S, and Z usually. And so a term that you might have heard is sometimes these patients will sound like they have a lisp because they're using that dentalized placement. And this is just another example. You can see, I think in this picture, the patient's actually pulling the tongue back, but it's more range of motion necessary to get placement behind the teeth because of those upper teeth are further back than they would be in normal occlusion. Patients can also have a class 2 or an overbite. This is common in patients with Pierre-Robin sequence. And in this case, if the bite is significant, if the overbite is significant enough, this patient's going to have difficulty getting the lips together to make any sounds that are made with the lips, so paba and in English. Similarly, sometimes patients will have an open bite, and like with the overbite, if it's significant enough, that patient's not going to be able to get the lips over the teeth to get bilabial closure for certain sounds. Additionally, in the overbite, there are also some distortions to those anterior sounds, T, D, S, and Z, that are, they sound slightly different to when there's a class 3 malocclusion present, but there are distortions there for those sounds as well. And these kinds of errors I'm talking about in relation to structure, we call them obligatory, just meaning that they're there because the structure is not supporting typical function. So speech therapy is going to change it, and we would need to change the structure to improve the function. So how does all this apply to research? Commonly in my field, craniofacial outcomes research, we're often asking, which surgical approach results in better speech outcomes, and which subgroups of individuals are at higher or lower risk. The challenges here are that how do we measure speech outcome? Who decides that the outcome we're measuring is the right thing or, quote, good versus bad? And what constitutes optimal versus a suboptimal outcome? And so these are challenges when we're talking about, the prevalence of VPI in patients is 30%. But what does that mean? Does that mean that 30% of patients are having additional surgery to correct VPI? Maybe. But there are times when the amount of difference that is perceived by a clinician, for example, is not the same as it is perceived by the patient and or the family. And so we need to have those discussions about what to do next. And when we're measuring and we're talking about, speech as a primary surgical outcome for cleft palate repair and for VPI surgeries. And so I want to make sure that when I'm telling my surgeon colleagues that, there's 10% of patients have VPI, I want to be sure that that isn't the only thing that I'm attributing value to in reporting outcomes. So if those 10% of patients, most of them are really mild and they're like, I'm not really bothered by it, so I'm not going to do anything about it. So that kind of moves the needle as far as like, is 10% good or is 10% bad? And it's gonna depend on who you're talking to across families. And of course, it's always fun when the patient and the parents disagree as well. All right. So as you can see here, there's plenty of opportunities for patients with cleft palate to ask these research questions, because the timeline of care for cleft palate begins in infancy and continues through adolescence and into early adulthood, and involves multiple surgical procedures. And so on the top here, the surgical procedures in dark blue are those that are pretty much done in most patients with a cleft palate. It's like part of the standard of care. And those surgeries in light blue up here, these are done if they're needed. So you can see kind of the downstream impact if you have multiple time points here where you've had additional surgery. What's happening down here is really hard to determine because so much has happened previously. And so the patients that you're investigating at this age are a really heterogeneous group. And it's hard to capture that in analyses. So this jaw surgery here is known as maxillary advancement. And what this is a structural change as a result of this surgery. It moves the maxilla forward. It can have both negative and positive consequences pertaining to speech. So they can have new VPI following surgery, and getting improved occlusion can help with the speech distortions on those S's and Z's that I mentioned. And so if we're talking about good outcome, bad speech outcome, which is more important, VPI or articulation or both? Should that alter surgical decision making? What kind of discussions are we having with the family? What are the patient's goals for functional and aesthetic outcome? So all of these things need to be considered in these patients. And so maxillary advancement surgery is done in the presence of severe maxillary hypoplasia. And so here we have the maxilla is highlighted in this mint green with these arrows. And you can see, like in that lateral x-ray I showed earlier, how far back that is from the lower jaw. And what should be happening is, a normal occlusion is where those upper teeth would be just on the outside of the lower teeth. So consequences of maxillary hypoplasia, you have malocclusion or an underbite. It can be aesthetically undesirable. You can have atypical tongue placement for speech, resulting in distortions. These patients might also have difficulty biting and chewing into foods because their teeth don't align in the front, and sometimes they don't align in the molars either. And it can also inhibit nasal airflow. So when maxillary hypoplasia is considered severe or extreme, management is going to require surgical or warrant surgical correction. So to put this in perspective, though, in the general U.S. population, just 0.3% of adolescents or young adults have maxillary hypoplasia that's severe enough to warrant surgical correction. Whereas in patients with cleft lip and palate, this prevalence grows to somewhere between 30 and 60% of these patients are going to have severe maxillary hypoplasia by adolescents. And this, again, this variability in number comes from type of cleft, early surgical history, team protocols, patient preferences. There's a lot of, that's why that number is kind of a moving target. The point being here that it's a significant proportion of the population defined by having a cleft palate than it is in the general population. So on the left, this is, again, a patient with maxillary hypoplasia. You know, notice the lower lip is further forward. Sorry. The lower lip is much further forward than the upper lip here. And so, you know, and the tongue is sitting here, so this patient likely has speech distortions related to occlusion. And so to correct this underbite or discrepancy between the maxilla and mandible, patients undergo a procedure that moves that maxilla forward or anteriorly with the goal of establishing a typical occlusal relationship following surgery. And so this is the same patient after maxillary advancement surgery, and you can now see the nice alignment of the lips, of the teeth. The tongue is now in a typical position, and so if everything else is intact, their articulation should be improved. And this patient must have had upper and lower jaw surgery, but you can see the hardware here and here from the surgery. When we look at this skeletally, we can see that maxilla has moved forward quite a bit from pre to post-op. And again, this improves tongue placement for sounds that we use frequently in English, S and Z. But it also means that moving the maxilla forward changes the relationship between the soft palate, which is attached to the hard palate, or the maxilla, and the posterior pharyngeal wall. And this structural change may result in new VPI after this surgery. And in adolescents, you know, they're at the end of high school, maybe starting college, starting a new job. There's a lot of big life things happening at this age, and so this is a not inconsequential possibility after this procedure. And so the craniofacial speech pathologists do an anticipatory guidance and baseline speech evaluation before the surgery to talk about speech expectations afterwards. And then part of our protocol is to see these patients 3 months after surgery so we can manage anything that comes up. So there's a conventional approach to maxillary advancement that involves cutting of that maxillary bone, and then they proceed with down fracture and separation to create a mobile maxilla. And then they will fix that newly mobile maxilla into position using internal hardware. And this is all done in a single procedure. And then when the surgery is complete, the goal is for the planned amount of advancement to have been achieved. In response to challenges presented in patients with cleft palate, though, surgeons have also started using something called distraction osteogenesis. This generally involves these same 2 steps in a single procedure. However, instead of securing the maxilla into the desired position, external distraction hardware is placed. And this extends the recovery of surgery, and it's, as far as burden of care goes, it's quite a bit different than the conventional approach. With this distractor in place, this device allows gradual movement over time, with the turning of a screw each day over 7 to 15 days, followed by a consolidation phase of an additional 3 to 8 weeks. And then it does require another procedure to remove the distraction hardware. And yes, the patient has this distractor on that entire 8 to 12 weeks, however long it ends up being. So again, in adolescents and young adults, this is a big deal. The clinical hypothesis, though, is that the rationale for doing this is that gradual movement over time allowed during distraction lowers the risk of postoperative VPI versus the conventional approach. So we went and reviewed the literature and found just 2 studies that have specifically been designed to assess this question of whether there's a difference in risk of VPI between the 2 surgical approaches. So this, there's one here that's a randomized controlled trial done in China. And there were a total of 20 patients that were randomized, so there were 10 in each group. And of note, they did limit their inclusion criteria to those needing just a moderate amount of advancement, so excluded those with a lot of advancement necessary. And they found there was no difference in risk of VPI between these 2 procedures. Another retrospective cohort study found that the prevalence of VPI in their slightly larger cohort was 50% lower in distraction compared to conventional osteotomy. So this is fitting with what the clinical hypothesis is. And so for my dissertation during the pandemic, I did another retrospective cohort study of a much larger cohort with nearly 200 patients who underwent either type of maxillary advancement at Seattle Children's. And after adjusting for type of cleft and the amount of advancement needed, I found that the prevalence of VPI is actually higher in distraction versus conventional advancement. So let's summarize the evidence here. There's no difference. It's better for distraction. It's worse for distraction. So great. That's fantastic. So it illustrates the challenges here. We're talking about, of course, different study designs, different analyses, but also how speech is measured. The way VPI is measured in each of these studies is slightly different. There's also slightly different inclusion and exclusion criteria. And so we end up with just a really confusing body of evidence that makes it hard to inform decisions. And so I didn't like that result. I couldn't figure out why it was that distinct. And clinically, I had my own impressions because I've been seeing these patients for years. And so we did an ad hoc review of the data in the EMR and found an imbalance of patients who underwent initial lip and palate surgeries at a prior institution or prior to international adoption or at another institution in the U.S. So with this information, we now know that the cohort in distraction versus conventional advancement were slightly different in my study because of this. And so we know that international adoptees are more likely to undergo late lip and palate repair. They're more likely to require fistula surgery, VPI surgery, and as well as other revision surgeries. So generally, they've had a lot more surgery from birth to where they're at in the timeline of late adolescence. We also know that maxillary advancement in cleft palate versus those with non-cleft is more complicated in those with cleft because of soft tissue scarring, atypical maxillary vascularity for multiple procedures, increased severity, asymmetry, and multidimensionality of the hypoplasia, as well as differences in velopharyngeal anatomy. And finally, we know that these characteristics of early care are associated with these characteristics attributed to increased risk in maxillary advancement. And so we ran a different analysis where instead of comparing the two surgical approaches, we compared VPI outcome between those who had surgery, all their surgeries here, and those who had surgeries elsewhere. And we found that the odds of VPI is higher in those that were repaired elsewhere compared to those that were repaired here in the following subgroups. Those with no indication of borderline VPI preoperatively, those with a smaller degree of maxillary advancement needed, and those with a history of VPI surgery. There was no meaningful difference in the odds of VPI between those who had initial surgeries elsewhere versus here, within those who underwent distraction or conventional advancement. And so do these results mean that in a real-world context, is this the final say? Well, of course not. How would patients in these different subgroups weigh risk versus benefit? And how could we get larger study samples to really address these questions and deal with the heterogeneity that's present in these groups? So this also comes back to how we measure speech. It can be measured in many ways, and as I mentioned, there are competing outcomes following maxillary advancement. So there's a couple things that are not accounted for when we're measuring VPI as the only outcome. First, I mentioned previously that articulation can improve with maxillary advancement surgery, and we generally measure this by just doing percent consonants in error or percent consonants correct, pre versus post. And then second, the presence of VPI based on a clinical diagnosis. We generally use an ordinal severity scale. They are validated, and we spend a lot of time making sure we're reliable. You can also use visual analog scaling. But as I mentioned, the presence of VPI based on a clinical diagnosis doesn't necessarily mean the individual would choose surgical management. And so they may not be concerned by it. So how do you interpret risk given these and other considerations? Well, what we need to do is be thinking about the bigger picture. And so speech acceptability has become a more commonly measured speech characteristic in addition to these other areas. And this is because it captures how much speech draws attention to itself in a person as different from other people that are the same age and gender. And it captures VPI and articulation within that measurement. And so speech acceptability also measured on an ordinal scale of severity or visual analog scaling, which is easier to analyze because it's a continuous variable, by the way. It has become much more a part of reporting outcomes as in a broader context. And finally, of course, patient and parent reported outcomes. We have something called the VPI effects on life outcome, or VELO, which is a validated scale that measures how much VPI might be impacting the patient and family in just everyday context. So there's a youth report for kids 8 and up, and then there's a parent or caregiver version as well. And then I'm also considering having the patient rate, this is written into my K, which we're hoping that third time's a charm on that one, how the patients rate their speech acceptability pre versus post to understand those differences. And so this diagram illustrates the big picture we consider when we consider the best approach to studying speech outcomes following maxillary advancement. In those with cleft palate, there are different surgical risks and benefits that may be weighted differently by different people. And there are different surgical approaches to consider that also may tip the scales on surgical risk versus benefit. The anatomic factors may inform preference for surgical approach independent of the potential risk for VPI. And finally, there are all kinds of psychosocial factors to consider, and any of these may both alter the patient's perception of speech change and their willingness to accept risk. In summary, speech sound production is complex. It is not measured by a single parameter, nor should it be. Structure and function is not directly correlated, and this is something to keep in mind if you're putting in a referral for further evaluation, so that you don't inadvertently set up the family with misinformation ahead of time. And we always need to consider perception. So just because I said you have VPI, I tell my patients that's a fact. That does not mean it's a problem. And I will ask the families, are you concerned about your speech or your child's speech? What is most noticeable to you? And that whenever they identify, would this be addressed by whatever the team's plan of care is? And so I just want to acknowledge that I work with an amazing multidisciplinary team, a big one, whose approach to patient care exemplifies the need to consider each child and family individually and to include the child and family in management decisions. Thank you.
Wow, thank you so much. What an amazing body of work you have. And while we wait, I'll open things up for questions in the room. Oh, I already see one.
Dr. Kinter, this was really fascinating. Thank you so much for sharing your work. I'm curious with the wide diversity of language, articulation, phonation amongst different languages and even dialects of languages, if surgical approaches, outcomes, and even decision to do surgery change with different language, and if research is stratified with language or just kind of centered around English.
Well, the short answer to that is currently the studies center around English, not because that's the right thing to do. But the challenge here is a different language will have different anchors for what is normal, for acceptability, articulation. Their phonology systems are different, and so we can't group them all together. And so in an ideal world, we would have a large enough data set to stratify by all these different things, including language and race and ethnicity, but we are still working on that. It is definitely something we need to consider. Yeah.
Thank you. Thank you for a fantastic talk.
Mm-hmm.
I was wondering, with your results on distraction, which seems to also be very invasive for the child during that 8 weeks, have practice patterns changed because of that? Because of your results?
I would hesitate to change surgical practice patterns based on a single retrospective study. However, because I work on such an amazing team and we have a lot of conversations, there's a lot of hallway discussions and when patients come through, I think what it has done doing this work here has increased the amount of discussion that we have prior to making big decisions. And there is plans and interest in looking at these questions in a lot more detail. Yeah.
Any other questions? All right, perfect timing. Thank you so much, Dr. Kinter, for all of your work.
Thank
and to
you.
your entire team. We really, really appreciate your time. And everyone, thanks for coming. We'll see you next week. Thanks.